चला गया, ऑनलाइन हो गया?
10 सेकंड से डिले होता है।
अच्छा, यहाँ पे नहीं आ रहा है इसीलिए। आ गया है, आ गया, आ गया, थैंक्स। It's coming online. Good morning, everyone. So today I'll be speaking about antimicrobial prophylaxis and therapy in acute leukemia. My moderator is Dr. Mukul Agarwal, sir. It's a very big topic, so I've tried to focus on few important points which are important in the management of the acute leukemia, especially those patients that we see routinely in our wards and OPD in the Department of Hematology at AIIMS. I'd be going through certain studies which were path-breaking and sentinel studies that led to the adaptation of different protocols. The primary guidelines that I've taken from are the IDSA guidelines, the ASCO guidelines, and the European guidelines from the ECIL group. So, infection constitutes the most important risk in acute leukemia, which has led to the concept of prophylaxis. And I will be speaking about the specifics of prophylaxis and therapy to some extent and special situations. Over the many years, over the last 30 to 40 years, there has been a paradigm shift in the overall survival and the event-free survival in acute leukemia. While the event-free survival has primarily evolved from better therapies to tackle the leukemia both in the upfront and the relapse status, the overall survival has a lot to do with the improvement in the supportive therapies, a primary aspect of which has been the better treatment of infections as well as better prophylaxis, understanding the different interplay that happens between the disease process, the treatment protocols, local infection rates and practices, which have led to more concerted efforts at curbing the malice of infection in acute leukemia. So what are the important factors that we have? Obviously, age and comorbidities remains the primary pillar which decides the mortality and morbidity of infection, the performance status which goes almost hand in hand, a prior febrile neutropenia episode, the depth of neutropenia which is determined by the type of cancer and the therapy that has been given, and also other modalities, for example, the environment in which the patient is treated, the amount of protection that's used by the attending healthcare workers, the family's understanding of the disease, amongst others. So I would first talk about what are the different severity category of patients who come with febrile neutropenia. And as you would be expecting, the most serious are the ones that have acute leukemia. So looking at the different relative risks which have been reported from multiple cohort studies to start with, acute leukemia has an 85 to 95 times relative risk of increased chances of febrile neutropenia amongst others. And an important thing to understand is that an acute leukemia post therapy or on a relapse setting, the risks of such infection increases multifold. Now coming to the treatment of the acute leukemia, as I just mentioned, it is not just the disease but the treatment also which predisposes the individual to the infection. And the more toxic the regimen to start with, the more severe are these infections, the more increase the mortality that also presents with it. As you can see from these ASCO guidelines based on the severity category, most of these regimens which are associated with a very high relative risk of febrile neutropenia and subsequent mortality are associated with acute leukemia therapy, classically anthracycline, cyclophosphamide, etoposide and very high dose cytarabine. Now, how did we figure out that fungal infections amongst others are important reasons for the infections which led to a death of many patients during the early phase. So this was one of the seminal paper that was published from the American Journal of Clinical Pathology, which looked at different patients from the old CalGB and the children oncology group, and they looked at patients at autopsy and how many of them had diagnosed fungal infection. In those times, obviously, candidiasis had a more preponderance than aspergillosis, as is evident, and obviously the main bulk of infection lied with those patients who had very aggressive malignancies. Topping the list was leukemia. Now, what is the situation in India? This was a study from the Department of Medical Oncology at AIIMS, which looked at patients with acute myeloid leukemia, and they looked at the different sites of infection, the different therapy modalities, and also how many of them were culture positive infections. So the most common site was obviously, as expected, would be the ENT oral cavity and the pulmonary tract, going almost hand in hand. And the most common infection obviously were gram negative, but this study is probably a little skewed because there were no diagnosed fungal infections in this study. What are data from some other centers? This is a study which looked at the real world situation of acute myeloid leukemia treatment from CMC Vellore. Out of 300 patients, 109 who opted for an induction therapy in that center in acute myeloid leukemia, 30 of them had an invasive fungal infection which was diagnosed by the URTC criteria. Amongst the other infections, the most common infection were obviously GNB, and that too 69% of them had a very high burden of multi-drug resistant organism. Amongst the cause of death, the most common infection that stood apart was obviously GNB. Amongst the 27 patients who died, 18 had a culture positive gram-negative bacilli growth. Do we have similar studies from the acute lymphoblastic leukemia setup? This was one of the earlier papers from the Tata group at Bombay, which looked at both the site of infection, the organism of infection, and how the infection patterns have changed over time. And obviously here the most common infection, this is a study which looked at almost 15 years of patients accrued, and 43 of them had infections manifesting as pneumonia. 58 patients amongst 154 had a microbiologically documented infection in the blood, and the most common infection happened to be again the gram-negative bacilli, predominantly Pseudomonas and Klebsiella. What about infections with fungus? Candida remained the primary fungal pathogen, which obviously I'll come to later how it has changed over time. Was there a difference in the percentage of patients who were dying secondary to infection after a proper antibiotic policy was used and there were stringent measures utilized to prevent cross-contamination of patients? Yes, with a p-value going towards a very high significance ratio. Over the initial 4 years versus the next 4 years, there was a significant reduction in the number of deaths second to infection. Is there any new data? This is the data from RCC Trivandrum, which looked at patients with acute lymphoblastic leukemia, primarily involving pediatric patients, and the primary focus of infection happened to be the lung and GI tract. And most of this data is from the induction period of acute lymphoblastic leukemia. And the predominant infection, again as expected, was gram-negative bacilli. Topping the list was Pseudomonas and Klebsiella. This is a very important study that was published from the Department of Hematology at All India Institute of Medical Sciences, which looked at multi-drug Acinetobacter blood infections, amongst other, in patients who present with marrow failure syndromes as well as hematological cancers. A total of 1,165 blood cultures were positive, of which 72.9% had gram-negative bacilli, and Acinetobacter, which is a non-fermenting gram-negative bacillus, was present in an odd 18.7%. This essentially highlights that there has been an increase in the GNB as well as the NF-GNB percentage if you look even from the present study. And this is where the modus of treatment lies in acute leukemia and determines how rapidly you act when a patient comes to you with febrile neutropenia. So just one slide on what happens after chemotherapy. As you can see, we have two arms of the immunity, the innate immunity and the adaptive immunity. The important part of the innate immunity are the mucosal and the skin barriers, which obviously gets denuded once the patient develops chemotherapy related neutropenia because there is mucositis. There is translocation of organisms across the gut barrier, and then there is a bacteremia. Together with this, the presence of a catheter, which obviously leads to more biofilm formation, increases the chances of bacteremia as well as fungemia. Prolonged neutropenia exposes the pulmonary bed to aerosols as well as spores from the environment, leading to the development of multiple forms of infection. One important part of this would be fungal pneumonia. This has been adapted from Mandel's infectious diseases. Now coming to antimicrobial prophylaxis and therapy in acute leukemia, The choice and extent of prophylaxis depends most importantly on the local infection and sensitivity patterns. I cannot think that I will just right away start isavuconazole when most of our patients will not be able to adapt that. So I'm going to adapt the therapy which would be most prudent for the patient population at hand, depending upon the cost, the follow-up period, the toxicity, and amongst others, how much of it is available in the market around us. One important definition of febrile neutropenia amongst the Petersdorf and Beeson criteria of neutropenic of fever in undiagnosed setting. One important is fever in neutropenic patient, single oral temperature of 101 degrees Fahrenheit or a temperature of 100.4 degrees Fahrenheit sustained over a 1 hour period, and the grades of neutropenia according to the IDSA defined as less than 1000 with severe neutropenia less than 500, profound less than 100, and protracted neutropenia any of these present for more than 7 days or anticipated to be present for more than 7 days. Now coming to fungal prophylaxis, which will be one of the crux topics here, we all know that there are three primary groups of antifungal therapies, most important being the azoles, which have been there from beforehand in the form of fluconazole. Now the newest entrance into that family would be isavuconazole. The mechanism by which they work is prevention of the activity of lanesterol demethylase. Then we have the echinocandins, which act against beta-1,3-D glucan synthase, which is important for the cell wall formation of the fungus. 5-flucytosine is a nucleic acid synthesis inhibitor, which is not very commonly used except for rare fungal infections like CNS cryptococcosis, which we do not see very often in acute leukemia. And probably the pillar of therapy in our setting becomes the polyenes, which is amphotericin, which forms sporins in the fungal membrane and causes loss of fungal material and death. So now coming to fungal prophylaxis, why, when, and which. So invasive mycosis, as I told you, continues to be the most important cause of mortality and morbidity in acute leukemia, especially during induction and especially during our setup. The most common malignancies associated with deep mycosis are myeloid more than lymphoid, because the neutrophil component is very rapidly and very deeply altered in myeloid malignancies. In a relapse setting, it would express much more deep mycosis than upfront therapy. One important thing to remember here is that till now no study has seen an improvement in overall survival with use of fungal prophylaxis. Having said that, it has definitely shown improvement in mortality with infection related causes. What are the patterns of infection? There are different patterns. Molds versus yeast. The molds we know are the Aspergillus, mucor, and Fusarium. Deep versus superficial. Oropharyngeal candidiasis versus hepatosplenic or fungemia of any sort. Site of mold infection can vary between pulmonary, sinonasal, gut, fungemia, and many other sorts. So this is one study which I took because it looked at a very long period of patients who were followed up even after the leukemia got treated and the morbidities that they developed because of prior fungal pneumonia, etc. So this is a study from the Italian group which looked at patients of acute myeloid leukemia and acute lymphoblastic leukemia amongst other malignancies and looked at the incidence of invasive fungal infection. As you can see, even in centers across some of the best centers of Europe, they had an invasive mycosis risk more than 6%. I'll tell you why the 6% is important. And as you can see, the most common fungal infection was Aspergillus, which has kind of replaced Candida from the previous groups. I hope I am edible to all. Now coming to the risk of death with Aspergillus and acute leukemia, as you can see that over the years the numbers of acute leukemia has increased, but so has slowly the numbers of Aspergillus, as we could expect with increased numbers, and the attributable mortality to aspergillosis remains at 1.9, which is a very high number. So in short, Aspergillus constitutes around 1.4% of the mortality, with 35% attributable mortality rate secondary to deep mycosis, which is a very high number. And similar numbers were reported in this study even in acute lymphoblastic leukemia. That means amongst all the patients who develop an Aspergillus related infection, 38% in acute myeloid leukemia and 43% in acute lymphoblastic leukemia would die, which is almost also what we see in our clinical settings. The numbers are no less for Candida, with almost 35% of patients developing a candidemia in AML and 36% in ALL succumbing to the infection, with an overall mortality rate being around 1%. Now, how do we decide the prophylaxis with antifungals? The most important thing to realize is that The local incidence of invasive mycosis is more than 6%, and definitely in our setup it would be upwards of 15 to 20%. Duration of severe neutropenia has to be more than 7 days. These two are the most important factors that determine the fungal prophylaxis and the intensity of the fungal prophylaxis. When we use more anthracycline based therapy, where we expect more mucositis, the risks increase. High dose steroid use, the risk of candidemia increase. Loss of mucosal barrier, catheters and C2, these are all related to the induction, hence I have put them in the subscript. So this is the final ASCO guideline of 2018. Patients at high risk of febrile neutropenia or profound protracted neutropenia, almost all patients of AML and a significant subset of patients of ALL will have that, needs an oral triazole or parenteral echinocandin. The echinocandin that has been approved in such setting is micafungin. If we expect the IFI risk more than 6% in the local setting, a mold active triazole, which can be posaconazole or voriconazole, can be used. Itraconazole, which was used previously in Europe, has gone out of setting because of poor tolerability. In patients where there is significant abatement of the lymphoid arm or very high steroid use, definitely cotrimoxazole has to be used, and these also need to be used in patients who are on any form of bortezomib or bendamustine based therapy because the increased risk of PCP infection. This is one very important study which was published from the MRC group, which looked at mold active compared with fluconazole prophylaxis to prevent invasive fungal infections in patients receiving chemotherapy or hematopoietic stem cell transplantation. There are very few studies which have looked at leukemia alone, so this is essentially an overlap between acute leukemia and hematopoietic stem cell transplantation, and these are all the studies that they have taken into account while they came across. One important thing to realize here is that the risk ratio favored the use of mold active prophylaxis compared to fluconazole prophylaxis. As you can see here, the present on the top part of the slide, the presence of proven or probable IFI reduced in patients who had mold active prophylaxis, as well as invasive aspergillosis, as well as adverse events during antifungal treatment discontinuation, which was a side effect of mold active prophylaxis. So concentrating on the first two parts of it, which also were statistically significant, patients who were on mold active prophylaxis, they had significant reduction in the risk of invasive fungal infections, tagged with an increase in the risks of drug interactions and need for discontinuation of this fungal prophylaxis because of drug toxicity. In this meta-analysis, there was a reduction in the IFI related mortality also with a relative risk of 0.62. However, 0.67, which was statistically significant. However, there was no improvement in overall mortality, which is what I had pointed in my initial slide. So the dictum, mold active prophylaxis warranted when the risk of IFI is more than 6%. There is classically no effect in overall mortality. However, there are no significant studies from India to disprove that, and in our setup, we would probably want to give it despite not its role on overall mortality. You have to consider the side effects, the drug costs and interactions, especially with azole, some example being vincristine with voriconazole, venetoclax with vorio or posaconazole, or liver dysfunction with any azole which precludes the use of dono-VCR or L-asparginase dosing during acute lymphoblastic leukemia. There are different protocols that can be used which are present in the drug monograph or any of the guidelines authority, which you can refer to how these dose modifications are done. So coming to a final slide on the prophylaxis of fungus, the NCC in 2020 that came in February, they have opined on the use of fluconazole or micafungin or amphotericin B products in ALL. Obviously, these drugs have less interaction with the 4-arm drug regimen in ALL induction. On the other hand, with MDS and AML, it is primarily a mold prophylaxis with posaconazole, voriconazole, and micafungin. Fluconazole is something that has been advocated but with extremely poor recommendation strength and something that we do not use in AML prophylaxis in our setup. Now, what are the possible narratives? What is breakthrough infection? Breakthrough infections are those invasive fungal infections either diagnosed or probable that a patient develops on already a fungal prophylaxis and adequate fungal prophylaxis with adequate trough levels in the serum. These are infections which can be either because of an extremely high spore load or because of resistance in the fungus. What are the neotherapy options? Isavuconazole. Primary prophylaxis versus secondary prophylaxis. Primary is when you start without the development of any fungal infection, whereas secondary prophylaxis is something that you continue after the patient has finished the treatment for the initial fungal infection. What are the dosage and formulation considerations? Different studies have come across low dose versus high dose amphotericin B prophylaxis, all the way from alternate day 1 mg per kg to daily 0.5 mg per kg to weekly doses of liposomal amphotericin B of 10 mg per kg. As of now, there is difference in opinion about which is best, but definitely in the adult population in acute myeloid leukemia, there is data to suggest that a single weekly liposomal amphotericin B of 10 mg per kg probably does as well as alternate day 3 to 5 mg per kg of liposomal amphotericin B or 1 mg per kg of conventional amphotericin. Then coming to posaconazole, which forms an important drug in our armamentarium, liquid as well as IV posaconizoles have variable liquid posaconazole have variable absorption, whereas IV posaconazole has an increased cost, need for line handling. The new advent in this group is the extended release tablet form of posaconazole, which has very little variation in gastric absorption, and a month back it has been launched in India, which probably will prove very beneficial to our group of patients. The new drug in this family is isavuconazole, and this study is as recent as last month from MD Anderson. They looked at 65 neutropenic patients with newly diagnosed AML and MDS, including some patients who were on venetoclax or FLT3 inhibitors, which we have started using a lot nowadays in our patients. Amongst these group of patients, only 4 patients had a breakthrough fungal infection with a survival rate of 90%. The follow-up of this study has been only 3 to 4 months, and newer patients are being recruited so that the data is yet to mature. Now, I have added these slides, which I will not be going through, which are the different azole antifungals, their dose, their interaction, and what they are best used in. But on the whole, fluconazole is not a mold active antifungal. Isavuconazole has shown benefit in mold active as well as yeast-like forms. Itraconazole is something that we do not use, so we would not go to. Posaconazole has benefit definitely in prevention of aspergillus and some zygomycetes. In fact, the trough level of posaconazole that is required for mucor is much higher than what it is required for aspergillus. Voriconazole is not used much as prophylaxis because of the chance of aspergillus resistance with it, but definitely it has a very strong anti-mold as well as anti-yeast action. Now coming to the polyenes, the amphotericin B, the lipid formulation, and the amphotericin B liposomal, of which the most commonly is the conventional amphotericin B, and the best being the liposomal amphotericin B. The problem with conventional amphotericin B involves primarily renal toxicity. They can produce a Fanconi syndrome, significant dyselectrolemia, classically being calcium, potassium, and magnesium, as well as renal dysfunction. There is no part of the kidney that is not affected by the amphotericin, all the way from the proximal convoluted tubule all the way to the collecting ducts. Liposomal amphotericin B is costlier. It has lesser amount of renal dysfunction and better tolerance. Coming to the echinocandins, micafungin has been advocated to be used as prophylaxis. Data on caspofungin as well as anidulafungin as prophylaxis is scarce. Micafungin shows good benefit against even the mucor group of fungus. However, against aspergillus, micafungin is probably not as strong as compared to posaconazole or voriconazole. So in a nutshell, posaconazole probably has the best coverage amongst the candida as well as the molds. Micafungin has better tolerability because of lesser drug interaction, but it is a tad less inferior in aspergillus therapy. The amphotericin group of drug has significant benefit against the entire spectrum of fungal infection, albeit with very high cost and significant drug toxicity. Now coming to PCP prophylaxis, pneumocystis infection is predominantly affected by deprivation of lymphocyte function and numbers, which happens in chronic steroid therapy, acute lymphoblastic leukemia, use of bortezomib, bendamustine, and some studies have shown rituximab. The treatment of choice continues to remain cotrimoxazole, and possible alternatives include dapsone and pentamidine. This is one of the very good papers that was published from the Mayo Clinic group, which looked at the different studies with cotrimoxazole prophylaxis, and as you can see, with cotrimoxazole prophylaxis, there was a significant decrease in the risk of both PCP infection as well as PCP related mortality, with a relative risk going down to 0.17 when mortality was concerned. Now I will go through the treatment of fungus in acute leukemia, and this is a vast topic, so I'll just brush through. As we know, what are the yeasts, the molds, and the dimorphic fungi. Honestly speaking, in the clinical setup, we are most worried about the mold because they are a little recalcitrant to therapy and the options are limited. Now, what are the different strategies? As I spoke about prophylaxis, which is fear and to some extent logic driven. Empiric is fever driven. Preemptive is evidence driven. And targeted is diagnosis driven. So the aim of prophylaxis therapy is to prevent going on to any of these, but most of our patients are on prophylactic or empiric therapy. In a targeted therapy, as far as molds are concerned, it is difficult to prove because it needs a lot of tissue for biopsy and culture. But nonetheless, we have patients who do grow aspergillus as well as mucor or fusarium in their culture. Now, coming to the different infection rates, as you can see, this study from MD Anderson from the 1990, the last decade of this of the previous century to the first decade of this, there has been a progressive increase in aspergillus, and the reason being advocated was the previous widespread use of fluconazole as prophylaxis, which led to increased chance of aspergillus, against which it was not effective. And this study also shows that there has been a progressive increase in the aspergillus risk, whereas candida seems to be dropping a little. Now, what are the different forms of infection? It is important to realize that even in neutropenic patients, they do have periods where they would not be having neutropenia, and they might already be colonized with aspergillus from their previous exposures. They might be having a hypersensitivity, which is known as bronchopulmonary aspergillosis, allergic part, and subsequently all of this can become infected once the neutropenia sets in and the immunity wanes to provide an invasive aspergillosis, which is an extremely fatal condition. So what is the basis of diagnosis for invasive aspergillosis? The correct host. You cannot say any patient who comes in with a fever or a PUO or any pulmonary pathology to have invasive aspergillosis. So the most important in this being the correct host, an AML or MDS patient, poor prophylaxis, increased iron overload state. I would want to tell here that it is not only the mucor which has an increased risk of infection with iron overload, but even aspergillus does it. Presence of indwelling catheter, altered lung architecture, and something which is very important to our setup is infected surroundings with high spore burden, which is common in some of the general side wards. The clinical symptoms are important: a neutropenic PUO, respiratory distress or cough, facial pain, palatal perforation, progressive jaundice, especially if these are not responding to the classical broad spectrum gram-negative cover. Radiological features, the classical important ones are the halo sign in the early neutropenic phase and the air crescent sign that happens post necrosis, and subsequently the different markers which are elevated or rising beta-gal, microbiology with histopathology, septate hyphae with angioinvasion, aspergillus PCR, which is highly sensitive and specific but yet not standardized. Of these, culture remains the most specific test with poor sensitivity ranging between 25 to 30%. Beta-gal from the blood has a sensitivity of 75% and a specificity of around 80%. You can add 5% to each of these arms if you are doing it from the bronchoalveolar lavage specimen if it is clinically indicated. So as I told you, the aim of therapy prophylaxis is after colonization. Preemptive is when biochemical markers like beta-gal are present or some radiology. Empirical is when only symptoms are present, and targeted or classical therapy is when you have a diagnosed case on histopathology or microbiology. So this is the URTC criteria. The proven ones are obviously in the presence in the non-sterile site of biomarker septate hyphae and culture, or just a septate hyphae or culture in a sterile site. And it goes all the way from possible when there is a classical host and you have a PUO and you have an amalgamation of different symptoms. So what is the ECIL guideline? The class 1A recommendation is voriconazole, which is given at a loading dose of 2 times 6 mg per kg on day 1 followed by 4 mg per kg. We have the facility of voriconazole level monitoring in AIIMS, and we do that routinely for our patients. The therapeutic level is between 2 to 5, the prophylactic level is between 2 to 5, the therapeutic level is between 5 to 15. Isavuconazole has recently been approved both by FDA, and the ECIL guidelines also uses it as a class 1A recommendation. Liposomal amphotericin B daily at 3 mg per kg. All the other ones, the recommendations are poor. An important thing to realize is that if you suspect a patient has a very high index and you want to curb the fungal load early on, combination regimens in the first week has been advocated, which is usually the presence of an azole as is voriconazole together with anidulafungin. The reason why anidulafungin has been advocated with voriconazole is because voriconazole is hepatotoxic while anidulafungin is hepatosafe. Even micafungin can be tried. However, again, the data on it is scarce. So just to reiterate, if you suspect a patient is sick and there is a high chance of fungal infection with a high spore load, you might warrant to give in the first week a combination with voriconazole and anidulafungin to shift it to voriconazole monotherapy later on from week 2 or 3 onwards. What happens if there is a breakthrough? Liposomal amphotericin B can be used if it has not been used. Liposomal amphotericin B together with the first line therapy can be combined. It is usually a combination of two drugs and never in isolation. If echinocandin has not been used, anidulafungin can be combined with voriconazole, or anidulafungin can be combined with liposomal amphotericin B. There is obviously no strict data, and it is basically an interplay and different permutation combination. But if you have a culture positivity, please look at the sensitivity pattern to decide your therapy. There are different other sites of infection. CNS aspergillosis would require the intervention of a neurosurgeon. Endophthalmitis, intravitreal therapy of voriconazole. Endocarditis definitely needs lifelong antifungal and possibly a valve surgery. Osteomyelitis definitely needs a surgery. Renal sometimes even will go on to need a nephrectomy. Now, what is the role of granulocyte? Granulocyte with an average dose of 0.6 into 10 to the power of 9 per kg has shown to reduce the duration of symptom but has no effect on overall mortality. I have a slide on it later on, so just hold on. What are the other molds? They're rare, but they're definitely there. So the most important amongst these are the mucor group, which includes Rhizopus, mucor itself, and Cunninghamella. They usually present as a much more protracted illness which have not responded to voriconazole, or the symptoms have worsened after voriconazole, because voriconazole has been shown to increase the incidence and severity of mold infection. They can have contiguous extension from the pleura to the skin or to the pulmonary cavity. They can have hard palate CNS extension, essentially everywhere where aspergillus can be present, except that there are certain subtle differences with mucor. They tend to have multiple lesions in the lung, unlike focal lesions of aspergillus, and they tend to be associated more commonly with pleural effusion than aspergillus pneumonia is. Fusarium is much more rare, but it is important to realize that if a patient has if a patient has necrotic or umbilicated skin lesions which are disseminated and which is usually associated close to a superficial blood vessel, please keep fusarium in your mind. And one good thing about fusarium is because of its angioinvasion, there is a very high culture positivity if you have sent it in a fungal bacterial culture bottle. So paired cultures both from line as well as from the peripheral poke is important to rule out fusarium. So this is one slide I wanted to show about mucor versus aspergillus because it is commonly encountered. As you can see in mucor, there is not much pleural effusion. There are classical nodules, and they can have sometimes very few number of nodules, unlike mucor, which tends to have more than 10 nodules. They can have concomitant rhinocerebral involvement in mucor, which is a little lesser than with aspergillus. They classically have pleural effusion, reverse halo sign. There will not be an increase in beta-galactomannan. There is an increased preponderance in patients who are poorly controlled diabetic, and the relative risk of iron overload with mucor infection is more than with aspergillus. Now coming to mucor therapy, the first thing that I would want to tell you is that mucor is not just antifungal. Mucor is antifungal together with need of surgery to remove the focus, and that is something we tend to miss out. The other important thing to realize is that we would always want to give liposomal amphotericin over amphotericin B because they need a longer duration, improve CNS penetration where mucor can have a sanctuary, and because there has been some studies which have shown better fungicidal activity of liposomal amphotericin, and that too at a much higher dose going from 5 to 7.5 mg per kg. The role of azole is extremely limited except for isavuconazole, and in places where surgery is mandated, it is important to involve those disciplines early on, which includes rhinoorbital cerebral infection, localized pulmonary lesion. Hyperbaric oxygen can be used in pulmonary mucormycosis, but with a low level of evidence. Now, one important thing to realize here is the role of deferoxirox. Deferoxirox can be given together with liposomal amphotericin, and it has shown in some studies to reduce the period of fever, but again it has not shown any mortality benefit. There strictly is no significant study to look at salvage therapy in mucormycosis, but again different combinations of antifungals, early surgery, and hiking up the dose of liposomal amphotericin. Definitely isavuconazole has been advocated for salvage therapy, which have not yet been adopted for SL6, but IDSA adopts it. Now this is one flowchart from mucormycosis. I would just go through in brief. Early involvement of high dose liposomal amphotericin B or fluconazole, disease staging based on imaging, early surgical consult. If the patient is not improving, then to add on an azole, which can be posaconazole IV formulation. Consider GCSF empirically because of neutrophil taxes to the areas where mucor is present, and consider deferocerox. Now coming to treatment specifics, minimum of 12 weeks for all moles are involved. Consider further treatment if neutropenia is anticipated to be present for a longer time. For fusarium, since there is high chance of culture positivity, it is important to look at the fungal sensitivity patterns, because the protocols and the guidelines mention that there is no uniform strategy for fusarium. Scedosporium is one more septate hyphae which is confused with aspergillus in the microbiology lab, so it is important to alert the lab if the patient has already been on good aspergillus prophylaxis or therapy, and if they find a septate hyphae, to look for scedosporium. The important thing to rule about scedosporium is that they are fungizome resistant, so we have to use voriconazole and posaconazole early on. Okay. Now I would want to look briefly into candidiasis. Candidiasis can extend from just a superficial infection like oral candidiasis all the way to deep-seated infections. Something that we constantly ponder about in our patients who have liver dysfunction with a pyrexia of unknown origin second due to neutropenia is hepatosplenic candidiasis. The important diagnostic and treatment vignettes are, when in doubt, look for candida. More often than not, it would be hiding somewhere, and a clinical examination would yield that. Sinonasal examination, ear cavity examination, ophthalmic examination, examination of musculoskeletal system and joints are pertinent to rule out candida infections. An ultrasound abdomen has higher sensitivity than CT scan for hepatosplenic candidiasis. If a better resolution is warranted, we have to do an MRI scan. Change indwelling catheters, reduce steroid dose early, and consider stopping prophylactic antibacterial, which increases the chance of candida colonization. So this is what happens in hepatosplenic candidiasis. There is an early dissemination, then there is a progressive increase in the alkaline phosphatase as the neutrophils drop. Candida microcolonies form in the liver, and as the neutropenia drops further, they produce this bullseye lesion in the liver. The ECIL guidelines has put different recommendations for the different candida species. To realize, the most common candida is Candida albicans, which is also the friendly one because it responds to almost all the antifungals. Echinocandin remains the drug of choice, but the other candida species like Glabrata and Cruce, they are inherently resistant to the azoles, so you have to give echinocandins only and not fluconazole at a high dose, or you can give liposomal amphotericin B. The important thing to realize is that Candida parasilosis has very high resistance to echinocandins and liposomal amphotericin B, and as you can see, that's why echinocandins becomes a B2 grade recommendation for Candida parasilosis. It is very strongly associated with line associated infections, so early change of indwelling catheters is important. This is a flowchart from the German Society for Hematology and Medical Oncology. I've kept it. If you want to revisit the slides, you can come to how a personalized management can be done. And these are certain clinical questions about how would you assess the patient during aplasia and during hematopoietic recovery. An important thing to realize is that neutrophils are important for the radiological and the tissue manifestations of fungemia. Sometimes a patient with complete neutropenia will have just cough and fever, and the X-ray or the CT film might be absolutely clean, whereas once the neutrophil counts start picking up because of the neutrophil response and the tissue response, you can see nodules, you can see necrosis, and you can see angioinvasion. To the extent that aspergillus fungal pneumonia can produce massive amounts of hemoptysis during the periods of neutropenia due to angioinvasion, and which can be fatal. So if you suspect a patient has a very high chance of a pulmonary mycosis, consider the clinical setup, consider treating the patient early, and definitely consider getting a pulmonary consult for a bronchoalveolar lavage and repeated imagings to pick up new findings that could have been missed before. Based on the site of infections also, different drugs have different penetrance and different concentration. One small thing that I'm going to tell you is that if you suspect a Candida urinary tract infection, give fluconazole because it has the best chance of urinary concentration. If you have much more deep-seated infections, go away from azole, give echinocandins or liposomal amphotericin B. You can revisit this slide to go through in details. Now coming to antibacterial prophylaxis and therapy, it is very wide. I will just brush through it. Over the 10 years from 1990 to 2000 in the West, there was an increase in the number of gram-positive infections. But again, thereafter, there has been an increase in the gram-negative infections, which this slide tells you. So in the early part of the 1970s and 80s, it was the gram-negative. Then in the latter part, it was the gram-positive infections. And again, now the gram-negative have taken an increasing trend. So one size doesn't fit all. The reason why I wrote the West advocates the use of levofloxacin prophylaxis, but it is not always important or prudent in India because of emergence of resistant drugs, increased chance of candida colonization. Levofloxacin forms an important drug for TB therapy, and using it early on might actually make it resistant to any latent TB. It is important to have stringent attention to hygiene, oral and skin care, and decontamination of sanctuary sites like nasal nares, perianal region, groin, armpit and ear cavity, especially for MRSA colonization. And one simple trick to use mupirocin ointment in these areas twice a day for 3 days before starting the patient on high dose chemotherapy. Importance to the healthcare's hygiene, healthcare etiquettes has been advocated by the NCCN also, and it is important to understand how much the role of it is in preventing infections. The NCCN and the IDSA advocates the use of fluoroquinolone prophylaxis, however, in the Western group of patients who have a prolonged neutropenia or very deep neutropenia. Now, statistically speaking, the ECIL did a 2017 meta-analysis on 2 RCTs and 12 observational studies, and they proved confirmatively that fluoroquinolone prophylaxis did not have any effect on mortality, albeit they had a reduced chance of bloodstream infections and episodes of fever during neutropenia. But very importantly, this study proved that fluoroquinolone prophylaxis resulted in increased colonization or infection with fluoroquinolone or multi-drug resistant strains, which is something we need to remember in our setup a lot. So this is one more systematic review. And in this study also, the only thing that fluoroquinolone did was to reduce the period of bacteremia during the period of febrile neutropenia, but did not have any effect on overall mortality, as well as it reduced the rate of secondary infections. However, in this study, it did not have an increased risk of MDR bacteremia later on after levofloxacin prophylaxis. Okay, now what did levofloxacin do to the pediatric group? So this was a good study that was done by the Children's Oncology Group year before, and they published in JAMA Medicine, and they looked at 2 different groups, both the leukemia patients as well as the hematopoietic stem cell transplant patients. They divided into 2 categories, levofloxacin prophylaxis and no prophylaxis. And the important thing to realize is that levofloxacin reduced the chance of bacteremia alone, both in AML as well as relapsed ALL, but quite funnily, it did not have any role in hematopoietic stem cell transplantation. This study was not powered to look at overall mortality, but on the ad hoc analysis, this study did not show any difference in overall mortality with levofloxacin prophylaxis. So our policy is we try to avoid levofloxacin prophylaxis in private ward patients. We take a history and physical examination to rule out prior or present TB, and we try to avoid long-term outpatient levofloxacin prophylaxis in patients with acute leukemia. In multiple myeloma and certain other situations, levofloxacin prophylaxis in the OPD basis is warranted. Now, the antibacterial therapy in acute leukemia is a subject in itself, but I would just hint on specific points. If a patient comes to you with febrile neutropenia, are there risk adapted strategies present which lets you decide whether this patient needs admission or whether this patient can be treated in an OPD basis? So the MASCC risk score model is something that can be used to look at whether this patient can be treated with oral antibiotics with regular follow-up in the daycare or OPD, or whether they warrant admission in the emergency. You can go through this. There are many other scoring systems used. I've taken this from UpToDate, which has looked at which are the patients who are at very high risk of neutropenia and subsequent infections. So any patient with AML who is on consolidation therapy or post-consolidation therapy, we usually try to keep in the ward. So just keeping it aside in our practice. In the ALL spectrum, a patient who is on the consolidation regimen or the Kaposi regimen of the augmented BFM protocol, they tend to have significantly longer duration of neutropenia and deep neutropenia. So they are very high risk patient and they present to the emergency. A low MSCC score obviously means that these patients are sick, and the presence of any form of cardiovascular dysfunction, which might be hemodynamic instability, oliguria, GI symptoms, which can mean there is neutropenic enterocolitis or a fungemia, hypoxia or a pulmonary infiltrate, the basic comorbidities of the patient, which can be diabetes, which can be previous COPD, these have to be taken into consideration and decide the initial antibacterial therapy. The basic goal is early initiation of broad-based antibiotics, which will cover the gram-negative. There are specific situations where we use gram-positive cover also, but the final aim is culture-directed antibiotic policy. Routine amount of cultures have to be sent and large amount of cultures have to be sent, preferably from a central line and a peripheral poke. They should be sent every 36 to 48 hours if the patient persists to have fever. It reduces the antibiotic exposure and cross-resistance, and it reduces cost. Daily clinical assessment together with infection markers like CRP and procalcitonin can help us to modulate the antibiotic therapy and monitor for antibiotic related organ injury, which can be liver, renal, which can be altered mentation with metronidazole, and importantly antibiotic associated Clostridium difficile diarrhea. The basic investigations include CBC, KFT, LFT, malarial smear. The neutrophil percentage is very important. Paired automated medium blood culture, if needed a fungal culture, especially after 1 week of fever, urine analysis and cultures, chest x-ray, and then subsequently symptom or finding directed evaluation, but importantly thorough clinical examination. The NCCN advocates the group of patients where we can give outpatient versus inpatient therapy. I will not go into that. But on the whole, if a patient presents to you with any of the high risk features, it is important to start a broad-based antibiotic. The preference in our department I would come to, but here they have advocated the use of piperacillin, tazobactam or carbapenem, which we essentially use if the patient has any cardiovascular instability to start with, or if they have been exposed to piperacillin or Magnex before. If the patient needs oral therapy, levofloxacin can be tried, or cefixime can be tried, or augmentin can be tried, provided the patient is not already on these therapy. These are the different doses of the drugs that have been used, the specific action and the side effects. I cannot go through these individual things, but you can go through that. It's present as NCCN, or you can also look through my slides. An important thing to realize is that both vancomycin and daptomycin is our not initial choice of gram-positive cover, but we instead use teicoplanin. Daptomycin is classically used for teicoplanin or vancomycin resistant bugs, or for vancomycin resistant enterococcus exclusively in the skin and gut and not in the lungs. Vancomycin resistant staphylococcal pneumonia or vancomycin resistant enterococcal pneumonia of the lungs, daptomycin cannot be used because daptomycin gets neutralized by the surfactant in the lung. Linezolid is the drug of choice for skin and subcutaneous infections, but important thing to realize is that there is a slightly increased risk of thrombocytopenia with linezolid, especially if it's used for a longer duration. The individual dosage of these drugs are changed based on the renal clearance, based on how much severe the infection is. Loading doses are used for certain drugs like colistin, etc., as well as teicoplanin. Okay, so if we have an underlying infection which we have diagnosed, how long do we give these infections? So for skin and soft tissue infections, gram-negative or gram-positive cover is 5 to 14 days, provided there is neutrophil recovery. If the patient persists to have fever, there is no neutrophil recovery, we always try to find out, is there any other infection? Is the bug that we have found out resistant? And in certain situations, we have to look if the disease has not undergone remission or relapsed. So these are the important things to realize. There is no single platform to suggest these are the requisite number of days for antibiotics. It is always judged consistent with the clinical situation at hand. But if the patient is having neutrophil recovery or anticipated neutrophil recovery, the patient is having improvement in his fever patterns, the CRP is coming down, the procal is coming down, general condition is improving, oral nutrition is improving, these are the time spans which can be given. But if the culture remains positive, we have to keep on adding to the duration of the antibiotic. The stopping of antibiotic is dependent on culture negativity. So for gram-negative or gram-positive bloodstream infection, we usually give for 14 to 21 days. For yeast, it is 2 weeks after negative blood culture. Staphylococcus aureus is anywhere between 4 to 8 weeks. But if there is a Staphylococcus aureus osteomyelitis, if a Staphylococcus aureus pneumonia with an empyema is present, we usually involve the specialist from pulmonary medicine and infectious disease or orthopedics, and we decide if they need a drainage procedure, they need surgery, or they need prophylaxis long-term therapy like with rifampicin. Now, why is there an increased chance of infection after chemotherapy? There is an obvious loss of the mucosal barrier, so there is a gut translocation of the bugs which are already present in us, and that is why the role of prophylaxis has always been looked at with doubt. If you give levofloxacin prophylaxis, obviously there would be an increased chance of multi-drug resistant bacteria which gains entrance into the bloodstream during the neutropenia and can cause a multi-drug resistant bacteremia. With neutrophil recovery, usually the mucositis resolves, the gut wall barrier becomes stronger, and there is less translocation, and obviously there is better neutrophil taxis to the areas of infection and better control. So what is the preferred approach in AIMS hematology? In the first inward fever spike, we look at the disease pattern, the chemotherapy, what is the anticipated duration and depth of neutropenia, and what are the prophylaxis. These three things should be done in the immediate 1 minute that we are seeing the patient. The first line broad gram-negative cover that we use is usually Magnex with or without amikacin. Amikacin is advocated if the patient is in shock, or if the patient has any kind of renal infection. But at the same time, we have to consider the side effects of amikacin, which is renal injury, which is hearing loss, and elderly patients are less able to tolerate amikacin, so alternatives should be thought about. Piperacillin tazobactam is considered better in individuals where an anaerobic cover is warranted, and we do not want to add on oral metronidazole. Piperacillin tazobactam have a better modus of infection control against anaerobic bugs. What are the situations where we need a gram-positive cover? Mucositis, indwelling CVC, perianal pain, oral ulcers, or patients who have already been on gram-negative cover and still manifesting infection. And I am considering all these in the absence of culture positivity. Is there a need for super added anaerobic cover? Piperacillin tazobactam is a good anaerobic cover, and there is no added role of IV metronidazole until and unless you are thinking something like an acalculous cholecystitis or you are thinking of an abscess. If you are thinking a gut pathogen like Clostridium difficile, give oral metronidazole and not parenteral metronidazole. If a patient is already on piperacillin tazobactam or something like a carbapenem, giving an IV metronidazole is of probably more harm than benefit. If the patient persists to have fevers or recruits new signs, there is cardiovascular instability, we consider carbapenem antibiotics. Because carbapenem antibiotics has dose-dependent killing, we would want the level of the drugs to be higher than the MIC for a significant period of drug. That holds true even for cefoperazone sulbactam and ceftazidime avibactam. So we try to give it as a long infusion over 3 to 4 hours. Add colistin if there is persisting fever after 48 hours of carbapenem, or early in the presence of any cardiovascular instability. Detailed clinical evaluation for assessment of infectious foci, change in dwelling catheter. At this point, imaging is definitely warranted. It can be an HRCT thorax, it can be a CECT abdomen, or a CECT PNS depending on the symptoms, signs, and the duration of the therapy the patient is on. Add antifungals if you are suspecting a pulmonary fungal infection or an enterocolitis. Ceftazidime avibactam is probably a game changer, and over the last 6 months there have been significant patients who have responded magically to ceftazidime avibactam, gone on to completely finish the therapy, and some of them are in remission and probably cured. Ceftazidime avibactam works against MDSR Klebsiella, but it is important to realize that it should not be given in isolation. For multi-drug resistant Klebsiella, we have to give it together with aztreonam. And the funny part about this is the active ingredient against MDR Klebsiella is the combination of avibactam and aztreonam. Ceftazidim's role is dubious. However, in India, we do not have an avibactam-aztreonam combination, so we give ceftazidime avibactam at 2.5 gram Q8 hourly and add on to that aztreonam. Special situations warrant special investigations and special therapy. If the patient has loose stools or GI symptoms, assess for Clostridium difficile associated diarrhea, which can be C. diff, ELISA, culture, or PCR. Consider downgrading the antibiotic cover because it increases the chance of CDAD. Add oral metronidazole. If the patient is not improving, you can give oral vancomycin. New studies have shown about oral stool tablets. However, that's a matter of speculation, and we obviously do not have a stool bank in AIMS, a therapeutic stool bank in AIMS. Assess for neutropenic enterocolitis. Get a CECT abdomen done. Consider adding or upgrading antifungal therapy. Look for acalculous cholecystitis if there is a right hypochondral pain, if there is increase in alkaline phosphatase or direct hyperbilirubinemia. Rule out viral infections like HSV, CMV or even HHV6. Rule out deep-seated mycosis like hepatosplenic candidiasis or pulmonary molds, as I have already spoken about. What are the options in MDR bugs? I just spoke about polymyxin, which is essentially colistin, which can be used. Definitely fosfomycin can be used. Tetracyclines like tigecycline and gram-positive can be used. However, it is significantly associated with toxicities, especially on the kidney and the liver. And importantly, it is very poorly tolerated. There is very high chances of nausea, vomiting. On the whole, if you have a carbapenem-resistant Enterobacteriaceae, use colistin or polymyxin B, tigecycline or fosfomycin. Now we have ceftazidime, avibactam, aztreonam combination. If you have a beta-lactam-resistant Acinetobacter species, try colistin together with meropenem. It is important to remember that you never give colistin alone. It has to be combined with a carbapenem antibiotic because colistin in itself is useless. Rare organisms like Stenotrophomonas multifila, the treatment of choice would be therapeutic cotrimoxazole, which is one double strength tablet for every 10 kg body weight. Fluoroquinolone at double the dose like ciprofloxacin 3 times a day or levofloxacin twice a day can be used. For vancomycin resistant enterococcus, linezolid or daptomycin can be used. Daptomycin preferred for all situations except for pneumonia, and linezolid classic for skin and subcutaneous infections. For vancomycin intermediate staphylococcus, linezolid can be used. Daptomycin, sorry about that. Some of the other new drugs like quinipristine, dalfopristine have not yet come to India. Now, just a brief overlook of what happens if you have a Clostridium difficile associated diarrhea. I'll take just 10 minutes more. If you have a Clostridium difficile associated diarrhea, please reduce the amount of antibiotic that the patient is on, provided there is no other foci of infection. Try to give probiotics, which can be just curd, or it can be something like bifidobacter, or it can be certain other combination of probiotic which are available in the market. Use vancomycin, or this is after metronidazole failure I'm talking about. Use vancomycin or fidaxomicin. We do not have essentially that. If it is worsening, then you add metronidazole together with the vancomycin or consider fecal transplant. If the patient has fulminant disease, give oral vancomycin together with IV metronidazole and rectal capsules of vancomycin. If the CDI is resolved, continue vancomycin for a period of almost 2 to 4 weeks, and thereafter try to routinely check if the patient is a Clostridium difficile carrier, because they might need a longer course of vancomycin. Do not use any other antibacterial prophylaxis that increases the chance of Clostridium difficile associated diarrhea. Supportive therapy is the most important bedrock in the treatment of febrile neutropenia patients. Adequate hydration is mandatory even if the patient is not in sepsis. Any patient who comes to sepsis other than these antibiotics, the surviving sepsis guidelines have to be used. You have to give 30 ml per kg IV fluids, classically crystalloids, which is normal saline or ringer lactate, in the first 1 kg, and thereafter replacement fluids. Vasopressors have to be started if the patient is fluid refractory, classically with noradrenaline, then you can add adrenaline. Involve the critical care physicians. Vitamin nutrient supplementation have to be used. Nutrition is preferred to be enteral if the patient is not able to take because of loose stools, because of severe neutropenic enterocolitis, then parenteral nutrition can be given. Growth factor support has to be started and continued, which goes without saying. Assess for features of any cardiovascular instability or hyperperfusion. Cold clammy skin, reduced urine output and reduced mentation are early signs, and it is important to see them before the patient develops shock. The BP might not be 90-60 to start with. It might be hovering at 160 with a tachycardia of 140, which is not matching with the level of hypertension. These group of patients needs early escalation of antibiotics and early IV fluids to go on to develop septic shock and organ dysfunction. It is very important to revise and recheck the antibiotics daily, and something we face a lot of problem, especially in C6 and C2 ward. What is the role of granulocyte transfusion? It is best in neutropenic patients with infection and anticipated neutrophil recovery. A patient with aplastic anemia who is on cyclosporin danazole, you do not know when his neutrophils are going to recover. There is honestly no role of granulocyte transfusion. There is an obvious foci of infection. The patient has an abscess, the patient has a bug positivity. Granulocyte transfusions do better than in patients where we are treating empirically. Directed granulocyte apheresis, which is dexamethasone and GCSF mediated, is superior to Buffycoat. However, none of the studies have shown any mortality benefit. This is one study which looked at granulocyte transfusion in patients when compared with only standard antimicrobial therapy. The primary endpoint was a composite of survival plus microbial response at 42 days. The success rate for granulocyte and control arms did not differ with any infection type. However, in a post-hoc analysis, patients who got more than 0.6 to 10 to the power of 9 granulocytes per kg, sorry for the misprint there, tended to have better outcomes. So 0.6 into 10 to the power of 9 per kg is something that you can never get in a Buffy code. For that, you need dexamethasone and GCSF. Unfortunately, in our blood bank, it is difficult to coordinate. We have tried to get it for a couple of patients. We have been successful in one. I'll just brush through antiviral prophylaxis and therapy. It is again a very vast topic, but it is important to realize that before you start any form of high dose chemotherapy, it is prudent to check the patient for any ongoing herpes simplex or herpes zoster infection. Ask them history for high risk exposure and do a serology for hepatitis B, hepatitis C, and HIV, and maybe add on a hepatitis B core antibody total, because some of these patients might be negative for HBsAg but can have hepatitis B core antibodies positive, which can lead to hepatitis B reactivation, especially during high dose steroid therapy. For hepatitis B virus positivity, obviously you will have to get the gastroenterologist on board. If they are just core antibody positive or HBsA positive, then you can start them on entecavir, which is preferred over tenofovir or lamivudine, and you have to continue the therapy till the patient is neutropenic or receiving steroid. For HCV antibody positive, you have to get a viral load tested, and if the viral load is positive, they need therapy. If there is HIV positive, it is a subject in itself. We have to get the ID physicians on board. But it is important to realize that even with any of these virus positivity, together with a multidisciplinary team, we can still go ahead and treat these patients and not consider them as a separate group. The doses, as we know, we use it commonly. Entecavir is used at 0.5 mg/d. Lamivudine has a lot of drug interaction and a high chance of resistance, so it's not usually advocated. Tenofovir alafenamide is what we prefer over tenofovir fumarate because of renal toxicity with tenofovir fumarate. So tenofovir alafenamide is used at 25 mg/d. The antiviral therapy is mandated to prevent reactivation of prophylaxis is mandated to prevent reactivation of herpes zoster and herpes simplex infection, CMV reactivation, adenovirus reactivation. There can be just seasonal infections like the common flu or rhinovirus, and evaluation and treatment is host and symptom specific. So what is the prophylaxis that we use for herpes simplex? The common protocol that we use in AIIMS is basically 400 twice a day for both AML as well as ALL patients, especially adult patients, and that is primarily to prevent herpes simplex virus and varicella zoster virus reactivation. High dose acyclovir has shown to have some benefit in CMV and HHV6 adenovirus, but probably not clinically significant in our status. Whenever a patient comes with any of these infections, the dose is obviously increased, but we prefer parenteral acyclovir compared to oral acyclovir because of problems with absorption in sick patients, and obviously because IV acyclovir is better. Studies have shown it is better in reducing the period of viremia. What are the other drugs that have been used in CMV infection and HSV infection? Cidofovir foscarnet, which we do not use much. Letermovir has been used both for CMV prophylaxis as well as therapy in rare situations, which is not available. Oseltamivir is obviously used routinely for our influenza virus at 75 mg twice daily. But it is important to realize is that if a patient is sick and you have a diagnosed influenza on PCR, we can go up to give 150 mg twice daily of oseltamivir for 10 to 14 days. It is important to realize that early initiation of oseltamivir is important. Within 40 hours of initiation of symptom, oseltamivir reduces virus-related symptoms. Beyond that, probably it only reduces the carrier state. So summary, infections continue to remain the most important cause of morbidity and mortality in acute leukemia. While early treatment remains prudent, broader and wiser use of prophylactic therapies to prevent infection has improved over time, and these forms of supportive therapy forms the backbone of infection management. Prophylaxis and treatment options should not be a one-size-fits-all. It should match the local infection and sensitivity patterns and medical resources. I would want to thank Mukul sir for this presentation, for moderating it. The major guidelines I have taken from are the NCCN 2017-20, the ECIL guidelines from 2007 to 16 onwards, the IDAC and ASCO guideline of 2018. I've used Mandel's infectious disease and online up to date. Thank you so much. Okay, I'm sorry, I didn't see that the volume was low. I'm really sorry about that. Can you hear me now? Okay, coming to Mukul sir's question on the treatment of aspergillus with posaconazole, uh, I would go to this slide if you can permit me. Yeah. So, okay. So as you can see, the ECIL 2016 guidelines does not advocate the use of posaconazole. The reasons are many. One is because they consider that most of these patients have been on posaconazole prophylaxis, so there might be in vivo resistance to posaconazole, as a result of which voriconazole is preferred. But what are those situations where we cannot give voriconazole because of drug interaction or because of liver dysfunction? The best therapy would be liposomal amphotericin B or isavuconazole. In the absence of isavuconazole, we can consider giving liposomal amphotericin B alone or liposomal amphotericin B with combination. If the patient cannot tolerate liposomal amphotericin B because of fluid retention, because of renal dysfunction, then posaconazole can be combined together with an echinocandin, which can be anidulafungin or caspofungin. That is the recommendation from the ECIL guideline. Are there any more questions? Mukul sir, did I answer your question adequately? नेट तो ठीक ही रहेगा ना? वॉल्यूम में थोड़ा प्रॉब्लम आ रहा था, मैंने देखा नहीं, बाद में पता चला. हाँ, आपसे ठीक आ रहा था ना, लैपटॉप में शायद प्रॉब्लम आ रहा था. Okay, if there are no more questions, thank you so much for your time. Have a good day.